In this short lecture, I would like to review the X-ray findings of atelectasis and pneumonia. This is a quick review of the lobar anatomy. So you can see that on the right side you have the right upper, the middle, and lower lobes separated by the major and the minor fissures. The minor fissure is oftentimes seen as a faint horizontal line on the AP or PA views of the chest. The major fissure is rarely ever seen unless there is some pathology going on in the pleural space, such as pleural effusion. And on the left side, you have only an upper and a lower lobe separated by the interlobar fissure. These images just highlight once again the lobar anatomy. So the right upper lobe is going to be superior and anterior, and when the right upper lobe collapses, it tends to collapse against the pulmonary apex. The right lower lobe lives posteriorly and inferiorly, and when it collapses, it will silhouette out the right hemidiaphragm. The right middle lobe lives anteriorly and against the right cardiac contour extending laterally. So when it collapses, it usually collapses against the right atrium and it will silhouette out the right atrium. When you describe airspace opacities on a chest radiograph, you use the same terminology that you use with chest CTs, talking about consolidation when the alveoli are filled with either pus, fluid, blood, or some cellular material such as cancer, where you can see air bronchograms through it, but you can no longer see the vessels passing through that lung segment. And you talk about ground glass opacities when you are still able to see the vessels through it. Pneumonia may present many different ways. On a chest radiograph, you may see a focal airspace opacity, you may see a lower consolidation, or in case of viral or atypical pneumonia, it might be interstitial thickening. This chest radiograph shows ground glass opacity in the left lower lobe and a small left parapneumonic pleural effusion, so this is a left lower lobe pneumonia. Otherwise, the right lung is clear, there is just minimal atelectasis at the right base, normal cardiomediastinal contours. This study is a good example of a right upper lobe pneumonia. You can see the sharp outline of the upper lobe by the minor fissure. So this is a focal airspace opacity in the right upper lobe pneumonia. The remainder of the lungs are clear. You can see that there is no associated volume loss. The minor fissure really did not travel more cephalad like if it would be with atelectasis. This two-view chest radiograph demonstrates a focal airspace consolidation in the posterior left lower lobe and also shows you the spine sign. When you look at the vertebral bodies on the lateral view chest x-ray, the vertebral bodies should become darker as you are heading inferiorly, and in this case this vertebral body just looks brighter, and that is because of the overlying airspace consolidation. While pneumonia fills up the alveoli and the airway, atelectasis is the opposite, is going to be collapse of the airway, so it should be associated with volume loss. Typically, you're going to see linear airspace opacities mostly at the lung bases with atelectasis. If there is a larger segment or an entire lobe involved, then you're going to see mediastinal shift towards the area of atelectasis, or the hilo moving up or down again towards the area of atelectasis. This is an EP chest radiograph showing collapse of the right upper lobe. So this is the interlobar fissure which moved superiorly. This should make you wonder what is the reason of the collapse of the entire lobe. Should prompt a CT scan and look for a right hilar or suprahilar mass. Otherwise, the remainder of the lungs are clear. This study is a perfect example of collapse of the right lower lobe. As you can see, there is a sharply defined airspace opacity at the right base, silhouetting out the right hemidiaphragm, while the right cardiac contour is not silhouetted out. So this is not a right middle lobe atelectasis, it is a right lower lobe atelectasis. The remainder of the lungs are clear. The patient has a surgical chest tube in place that's in satisfactory position. The side hole is within the thoracic cavity. There is a left subclavian line which terminates at the distal SVC, a tracheostomy tube in satisfactory position overlying the tracheal air stripe, and there is a feeding tube in the stomach. You would like feeding tubes to be in the duodenum, so this is not low enough. Compared with the prior exam, on this study, the airspace opacity silhouettes out the right cardiac contour, and on the lateral view, you can see a wedge-shaped dense consolidation anteriorly, so this is a very typical presentation of a right middle lobe atelectasis. Lastly, this is an exam showing complete whiteout of the left hemithorax. Now this makes you wonder if the patient has complete collapse of the entire left lung with mediastinal shift to the left. You can see that the trachea is shifted over to the left side as well. The right lung is hyperexpanded, but I just threw this in for fun. Actually, this patient does not have atelectasis, but the entire left lung is missing. And here you can see the surgical clip, so the patient had a left pneumonectomy. After pneumonectomy, the mediastinum shifts over to that side, and oftentimes the leftover place in the hemithorax fills up with fluid. So this is probably just some fluid around the mediastinum.